Hello, my name is Ravi Vij. I am from My Cancer Haven, and in our Conversations with Cancer Experts series, today we have the honor of having Dr. Sameem Abedin, who is Associate Professor at the Medical College of Wisconsin in Hematology, Medical Oncology. And we're going to talk about some emerging areas in this field of what was formerly focused on myelodysplastic syndromes, but new entities have emerged over the last decade, CHIP, ICUS, CCUS, and this new entity of Vexas syndrome. So to educate us about this, welcome here, Sameem. Glad to have you here today.
Yeah, good morning, Ravi. Thanks for the invitation, and I look forward to discussing these related entities with you.
So I guess to put it in context, obviously we've known myelodysplastic syndromes for a long time. And so that is when you have, overt disease, and pathologists can look at changes under a microscope. But some of these entities that we're going to first talk about precede that. So help us put in context. So what is this entity CHIP?
Sure. So CHIP, or clonal hematopoiesis of indeterminate potential, first of all, represents, as opposed to ICUS or some of the other syndromes, potentially a state you could find where there are still preserved hematopoiesis, in other words, normal counts. And so where, we encounter CHIP patients in clinic more recently, there's a variety of indications now to be performing next generation sequencing, potentially from the blood. So in the setting of a variety of solid tumors, liquid biopsy has become a standard of care. There are some patients that are getting so-called executive screenings for which genetic testing and imaging is being performed. In the context of these studies, what is being identified are entities where a certain population of blood cells have shared genetic features to them. So in other words, next generation sequencing is sent off the blood, and these tests are positive for a population of blood cells that have a certain mutation that links these cells together. So these are the same sort of cells genetically in an expanded fashion. So these NGS tests, they usually have a sensitivity of about 2 to 3%, when you send it off the blood. So by definition, these populations, at a minimum are, 2 to 3% of the blood cells that are being assessed. Certain abnormalities such as DNMT3A, TET2, ASXL1, these are certain mutations that could be seen then that could lead somebody to think that there is this CHIP going on. So in terms of when we find this, so this is sort of a progressive disorder that we see with age. So as individuals age, the proportion of patients that are identified to have CHIP increases, up to 15% of individuals at age 65, a higher proportion at 70, 80 per decade. And increasingly, what we are finding is that it's a very heterogeneous state once CHIP is being diagnosed. Certainly, there are aspects of CHIP that are potentially linked to adverse outcomes. So with CHIP, there may be a component of autoimmunity that can lead to cardiovascular disease, potentially dementia or other sort of cognitive disorders. There's some thought that actually CHIP is a favorable sort of acquisition because it preserves hematopoiesis. So in other words, a population acquires a mutation so that the bone marrow as it ages can continue to make blood in the appropriate fashion. So it's a dynamic sort of diagnosis at this point, certainly with some adverse features to it, such as autoimmunity, but also potentially some favorable features, in other words, maintaining, healthy blood counts and, health in that fashion as well.
So as you said, then healthy blood counts. So these patients have usually got, I guess, preserved blood counts?
That's right. So as opposed to sort of the other disorders that we'll discuss, like ICUS, CCUS, MDS, Vexas, typically CHIP, one of the features of this is that there's preserved hematopoiesis. So in other words, you're not necessarily detecting any cytopenia.
So why would you, in the first place, go and do an NGS? How is this picked up? If counts are normal, what is the impetus to look for it?
Yeah, so again, CHIP is usually an incidentally discovered disorder. So, NGS or genetic testing in the blood, there are wide applications for it these days. So, again, in the context of patients who are undergoing treatment for solid tumors, increasingly cell-free DNA assays are being used to detect response to therapy. If there's good or deep response to therapy, if there's loss of response to therapy, these blood-based assessments are being performed. In the context of these blood-based assessments, we know that there are certain mutations that are paired with their solid malignancy, but then there are these mutations that are typically seen, in hematopoietic cells. Again, these DNMT3A, TET2, ASXL1 mutations are typically mutations that are seen in hematopoietic cells. And so that's probably the most frequent context within which I encounter CHIP. Outside of that, again, there is this concept of, sort of full screening for potential or risk for malignancy. In that context, patients are getting blood-based tests performed. Within these blood-based tests, these CHIPs have been identified. In a research context, the way that CHIP was really defined was there were large population studies in Europe, in the UK and in other countries where blood-based NGS samples are being sent. And that's where we get some of this epidemiologic data as to, how frequent this occurs in the population.
So you mentioned that there could be associations with cardiovascular disease, with even dementia. So is there a unifying kind of hypothesis as to what is this the bone marrow leading to changes in these other organ systems, or is it a more complex, manifestation of a systemic disorder?
Yeah, so I think, in terms of the link, there is a frequent association with full-blown malignancy or MDS and autoimmunity. So these conditions, so MDS and autoimmune disease, are known to be in pair with each other. CHIP, CCUS, these disorders or conditions are considered to be pre-MDS conditions or conditions that can lead to it. And so that's where the thinking behind kind of whether there's an association with autoimmune disease and CHIP has sort of been, first, questioned. And then what we see is independent of regular risk factors for cardiovascular disease in patients who are identified with CHIP, these patients tend to have more cardiovascular complications, and that's where this association, in other words, the presence of CHIP has been linked, to increase the risk of cardiovascular complications, heart attack and stroke.
So I think you already went over this. Do you have much to add over how you diagnose CHIP? I think you mentioned NGS, you mentioned some of these mutations.
Yeah, so I mean, in order to identify, similarity, so what we're really defining by CHIP is there is an expanded genetically identical population within the blood. Genetic testing is how that's determined. And so, NGS, if performed and a population is identified where, there's a certain proportion of cells with these genetic abnormalities, that's where CHIP diagnosis is made. And so it's largely through NGS sequencing.
And I think we've also talked about its implications in terms of developing malignancies and cardiovascular risk. So we'll move on now to another entity, ICUS. So what can you tell us about this entity?
So as opposed to CHIP, for which there is not necessarily a cytopenia, ICUS, in the other hand, is a condition where there is cytopenia. And so, macrocytic anemia most frequently is identified. Other cytopenias, leukopenia is identified. A bone marrow biopsy or, comprehensive testing for nutritional disorders, autoimmune disorders is done. And there's no identified reason for this. And so this is a sustained cytopenia without a clear explanation. And so what is known is, I mean, this could represent something that could lead to MDS in the future. These are patients who actually may have cytopenias that even get to the point of near transfusion or, requiring supportive measures, but not sort of a level of dysplasia identified, not with a genetic disorder identified that can clinch the diagnosis essentially.
So I guess in CHIP, you have genetic findings on NGS, but no cytopenias. Here you have cytopenias, but no genetic findings.
Right. Like it's really ICUS where it, is labeled ICUS, patients who are labeled with ICUS are these patients who you have a very, very strong suspicion for MDS. You have a cytopenia for which you highly suspect MDS. However, there aren't the parameters that are necessary either by pathologic assessment or cytogenetic or molecular assessment to make that diagnosis. So in other words, other causes have comprehensively been excluded, and we think there's a pending or impending bone marrow failure disorder, and that's why these patients, you almost watch as if they're a low risk MDS patient.
So what about this entity CCUS?
So then CCUS is a step up from ICUS in the sense that there is now evidence of clonality. So, how we discuss or define clonality in CHIP is really by sequencing. So you identify a population that has a shared sort of mutation. So for CCUS patients, essentially, you do comprehensive testing. You may not meet criteria to make the diagnosis of MDS. There isn't a significant amount of dysplasia or an MDS defining lesion. But when we do next generation sequencing, what we identify are some of the mutations you see in CHIP. So the same DNMT3A, TET2, or ASXL1 mutations most frequently. And so you know that there's some sort of clonal process occurring, concurrent to the cytopenia that you're identifying. These patients, as opposed to CHIP patients, the presence of, for instance, a macrocytic anemia along with a clonal abnormality are at higher risk than CHIP to subsequently develop MDS. And so these patients require more careful monitoring because they tend to have a higher rate of progression to MDS.
So do any of these entities, CHIP, ICUS, CCUS, need treatment?
So at present, treatment is mostly in the context of clinical trial. Treatments that are being evaluated in this patient population are mostly oriented around autoimmunity and inflammation, and perhaps a thought that mitigating inflammation or autoimmunity immunity can mitigate some of the complications associated with having these conditions, such as cardiovascular disease, and potentially slowing the progression to MDS. So there is no standard treatment at this point. What I will say about CCUS is if there is a cytopenia present, and if there is a particularly high-risk mutation that is identified, so not, for instance, DNMT3A, TET2, or ASXL1, but for instance, some of these patients may present with also TP53 mutations or abnormalities, mutations in PPM1D. Those patients then have an even higher risk of progression to MDS, a higher risk of progression to an aggressive MDS. Those patients should be very carefully monitored. If their age is, kind of within the parameter, there should be some consideration actually for, is a transplant or some sort of therapy, or what is the best therapy that would be required when MDS develops. That should be considered, So I think a CCUS patient with a high-risk mutation, if there are scoring systems that actually exist that can tell you whether they have a high risk of progression to MDS, some of the groundwork could be laid so that, efficient therapy is delivered when MDS occurs.
And then another entity that has started getting a mention in the literature, the Vexas syndrome. So what is this Vexas syndrome?
Sure. So, in the spectrum of acquired mutations amongst hematopoietic cells, Vexas syndrome is a newly identified entity oriented around a particular somatic or acquired mutation in this X-linked gene UBA1. And so we've known, essentially there is this connection between autoimmunity and MDS. So that is an established link. In MDS, frequently, these patients co-present or pre-present with autoimmune disease. So for Vexas patients, what you see is a specific sort of spectrum of autoimmunity. So these patients typically present with either like uveitis or dermatitis, potentially some sort of inflammatory, sort of inflammation in the lung leading to hypoxemia. So the spectrum of sort of, or they can sometimes present with chondritis as well. So significant pain, skin conditions, uveitis, and then also in that context, cytopenia. So essentially that's where then the workup can potentially lead towards the identification of Vexas syndrome. So essentially, in the context of these autoimmune manifestations, um, you know, progressive anemia, progressive leukopenia, which then prompts next testing, which could be either blood testing or bone marrow biopsy. When these tests are done, an NGS is sent, and now, the standard should be that if MDS is suspected, along with cytogenetics, NGS should be sent. What's seen then is the presence of a mutation in UBA1. And then in addition to that mutation, essentially what we call a high variant allele frequency or a high proportion, of cells, possessing this mutation. This mutation essentially affects a enzyme which is pretty important in terms of processing proteins. So when this mutation occurs, the processing of proteins is disrupted. This disruption can kind of perturb the immune system, and then essentially you see sort of this kind of pan-autoimmune, autoinflammatory sort of condition.
And I guess this entity does require some attention, some treatment.
Yeah, I mean, these patients, present with cytopenias, but also present because they're highly symptomatic, So the patient that I had recently seen with this disorder, significant sort of pain complaints, significant sort of issues related to chondritis. And so generally speaking, sort of a significant impact in terms of quality of life, functionality. And so if identified, then almost universally, due to the impact of autoimmunity, some sort of intervention is necessary. Usually the intervention is similar to how you treat autoimmune disorders. So first-line therapy is corticosteroids. There isn't really a defined treatment algorithm or paradigm for these patients. So after corticosteroids, if there's continued symptoms, then treatments with potentially immune suppressants. There's some investigation into other sort of novel immune agents such as ruxolitinib. These are sort of the treatments that are considered if Vexas is identified. If particularly um, if it particularly affects quality of life, if severe, interestingly, these patients are also considered for allogeneic transplant, as a means to sort of rectify this autoimmune disorder. And so, the spectrum of treatment is really not well defined and broad. It can go from just steroid therapy all the way to allo transplant. So, really where the research is necessary is to kind of really identify what the best management is, what not over management is. And, I think that's something that hopefully there'll be some clarity about, in the coming years.
So you mentioned allogeneic transplant. Is there a role for other drugs that as hematologists, have in our armamentarium, like HMAs? Do they seem to help these patients?
Yeah, so these treatments are attempted, so at the end of the day, we have seen some patients with MDS, present with some sort of autoimmune uh, co-condition, steroids are used, TNF alpha agents are used, and then, they still have sort of refractory sort of manifestations of disease. And so there are some that use sort of lower treatment schemas of HMA. So as opposed to the traditional 7 days of AZA, what I have seen is, sort of AZA at a lower dose or at a lower frequency of dosing, lower dosing of decitabine. There's no uniform response to that. However, there are some patients that may respond. There are some patients who continue to have, cytopenias as well as sort of the manifestation of autoimmune disease. So that certainly is something that could be considered and is frequently considered after failure of immune suppressive therapies or corticosteroids, but certainly not not necessarily a treatment with high efficacy.
So, and if they do work, do they just rectify the issues with the blood counts, or do they also have any effects on the other autoimmune manifestations if we treat them as a hematologist?
Yeah, so I have a patient, who I co-managed, and there's potentially both, so in that instance, it was sort of primarily cutaneous abnormalities that this patient was dealing with that, he was put on TNF alpha inhibitor for. In addition to this cutaneous manifestation, there was also thrombocytopenia in this particular patient. So platelets were, kind of in the 40s, 50s. And, what we saw was stabilization, mild improvement in the platelets with a strategy of, decitabine every 6 weeks. So platelets went from 40s to 90s to 100. So there was improvement in thrombocytopenia, as well as an ability to come off of TNF alpha therapy. So when it does work, it can lead to de-escalation of immunosuppressant therapies, which, come with their costs as well.
Who do these patients usually present to? Is it a hematologist first? Is it a rheumatologist?
Yeah,
Who?
so it's primarily rheumatology. However, once cytopenia is discovered, then hematologists, typically are involved in management. And so, Vexas syndrome very frequently leads to some sort of, moderate cytopenia, whether it be anemia, leukopenia, or thrombocytopenia. And so from that standpoint, with the frequent association of cytopenia, rheumatologists may initially see these patients, but then these patients are referred to hematology.
Well, I really want to thank you very much for taking the time to educate us about this expanding set of acronyms that we have in the area where MDS used to be a solitary entity. And I really appreciate you taking the time to educate us about this and the audience. And I hope I can reach out to you in the future for another podcast.
Yeah, absolutely. No, enjoyed discussing these topics and, open to any questions that kind of lead after this conversation.
Thank you very much.
You're welcome.